good morning again, everyone. We're very fortunate, as DiPietro shared this morning, to have Dr. Barbara DiPietro, who is the Director of Policy for the National Council on Healthcare for the Homeless. So with that, Barbara, why don't you come on up?
Of all of the things that you have on your plate in the hospital world, the fact that this is an issue that warrants this kind of attention, I think, is telling to where we are in this country with how housing and our crisis in housing has become our crisis in healthcare. And policy failures that have happened broadly and have been happening for decades now actually are rolling into our front door, and then this is our problem that we now have to address. And I feel like that's a framework that we need to be honest about as well. So one of the things that I'm going to be framing through today is just kind of talking about, like, how do we operate in an environment that is broken, and how do we participate in fixing it? One of the things that I find interesting too, on Tuesday, I was at the conference for the National Association of Medicaid Directors. Curious if anybody here was there in DC for this annual conference. So you've got a room of about 1,000 people, obviously the 56 Medicaid directors, but then the whole universe that goes around Medicaid. And I think, actually, we moved the table so I could do a little bit. I know I'm right before lunch, so that's always the hard spot. But in 45 minutes, we're going to cover a whole lot. At the Medicaid Directors Conference, one of the things I thought was really interesting is that they had a plenary session featuring the Medicaid director from Washington State and the Medicaid director from Arizona State. And they had a plenary discussion on housing and homelessness at the Medicaid Directors Conference. And again, all of the things that Medicaid could be talking about, and they're focused on housing and homelessness in a plenary session. I thought that was pretty great. And they were talking about a lot of the innovations that they've worked into the Medicaid state plans, how they're doing their partnerships, their collaborations, how we're kind of putting all of this under the rubric of social determinants of health, how we're bringing together medical care, social services, all of the things that we talked about and were talked about in the last panel discussion, what that looks like in the Medicaid world. I thought this was fantastic. What I also think is telling is that last year at this exact same conference, they had a plenary session focused on housing and homelessness. And last year when I was sitting there, I had a little mind explosion. I was just like, wow, they're focused on housing and homelessness. And they had a panel of Medicaid directors last year. And I remember that one of the guys was from the Medicaid director in Michigan. And he did not come off as a radical guy in any way. He came across as a brought into this issue kicking and screaming because he did not see this as an issue that Medicaid should be involved in. And he himself talked about how the fundamental failures around him left him no choice but to now care about homelessness and housing and how that is impacting his Medicaid program in his state. Again, not a liberal state, not a radical, but again, thinking about how this is pushing people in directions that they hadn't planned on going. So a little bit about us. National Healthcare for the Homeless Council, for 30 years, we've been doing training and technical assistance on best practices in homeless healthcare. And I find that statement alone to be an indication of the concern, right? For 30 years, we've had to develop best practices in homeless and healthcare. Back in the early 80s, when homelessness was first becoming a bigger thing, and we were not only doing deinstitutionalization, where a lot of people with very significant behavioral health issues were coming out of institutions into communities, and we didn't fund the appropriate interventions there. At the same time, we were also in cities across the country, we're pulling down SROs, cheap boarding homes, and other housing, affordable housing options. And then that just kind of fueled, also coupled with a federal disinvestment in housing over the last 30 years. So we're seeing this culmination of things coming together. When we first started doing this, we opened with 19 healthcare for the homeless clinics, and we thought, you know what, this is going to be a temporary thing. We're going to put ourselves out of business. That was actually our motto. We're going to put ourselves out of business because there's no reason to have homelessness in America. Well, we must be the worst business people ever because we're now 300 projects across the country, 45 of them here in California. And I want to give a shout out to my members. Dr. Norris with Father Joe's Villages, obviously a great member with us. And then also family, Family health centers, thank you. And so really excited about this, but we are primary care, FQHCs, specifically focused on people experiencing homelessness, and we're doing the kinds of care coordination and case management and putting together a lot of that model that was talked about in the last panel in trying to do more interdisciplinary care. So that's what we do. And so one of the things I wanted to try to do today was talk about homelessness. We can't talk about homelessness and not talk about housing, so we'll talk a little bit about that. But then let's talk about what medical respite care and what that piece is, because I think the supportive housing we've been talking about for a number of years. We've got a lot of good evidence base on that. We're starting to bring those programs to scale. But how does medical respite fit in to complete that continuum and fill the gap? And then how do we talk about hospitals' roles in addressing patient and community needs? So we'll start with just some of the baselines here. And so point in time counts. These are notoriously difficult. I find the methodology to be really concerning, but it's the only data that we have in terms of kind of a systematic nationwide thing. So last PIT count found over 500,000 people homeless on any given night. We can see, though, that the trend line is coming down. And there's a lot of folks who are really saying, hey, we're starting to end homelessness, which I find curious, but I'm curious to also to hear, by raise of hands, how many people here in their experience are seeing homelessness decrease in their communities, in the hospitals, okay? And then some of the point in time count here in the state of California, almost 130,000 people, again, just counted on one night. And that doesn't count a lot of folks that eluded that count, doubled up, and things like that we know there. But this is the kind of just baseline numbers, likely much higher. And then I don't think that anybody in this room doesn't understand the connection of homelessness and health. But as we are moving forward and we're talking with legislators and we're talking with your board and we're talking with people who don't live and breathe this every day, a lot of times you need to really put together the pieces so that they understand the cause and effect of what we're looking at right now. And a lot of times people do not understand, lay people, don't understand the connection between homelessness and health. And it's shocking, actually, how many politicians do not understand the connection between housing and homelessness, but it's a whole other issue. So one of the things is that as you are talking to your partners, and people that are working with you to figure out how to fix all this stuff, we've got to go through the basics. And how do people understand that poor health is causing homelessness in this country? And that the reverse is also true, that homelessness causes new healthcare problems, it exacerbates existing ones. And then the experience of homelessness is a crisis, and it's trauma in and of itself. It makes it harder to engage in care. It makes it harder to know who your case manager is. It makes it harder to know where you're supposed to go or how you're supposed to manage your health when you're living under a bridge, living in your car, or in an overnight shelter. How does that work? How do you manage 5, 6, sometimes 10, 11, and 12 medications? Where do you keep your insulin that needs to be refrigerated? Where do you keep any medications that aren't going to be stolen from you on the street? There's a litany of things that we really need to connect the pieces so that people understand why homelessness and health is there's a reason why housing is a social determinant, is because so much of this is driving poor health. And then it is not a surprise to see that people who were homeless have got really high rates of chronic and acute illnesses, behavioral health, and all the things that are rolling into our front door, unmanaged. And so this is the kind of thing where we're also seeing very high utilization, emergency rooms, inpatients, but not just in the healthcare system, it's also jails, detox, EMTs, court systems, police. Our community is spending a lot of money. And again, this is a conversation we've been having for a long time. But at the end of the day, we'll spend $1 million on one person at the end of the year, still homeless, still mentally ill, still schizophrenic, still has an A1C that's off the chart and still coming in to see you about 100 times in a calendar year. This is not money well invested. And so again, if we're thinking about like how we're using our resources, we spend a whole lot of money, but we don't get any kind of quality from that. And then social services needs, obviously we just talked a lot about that. And then what we have too are there's barriers to care. And we're always talking about how do we bring down barriers? How do we make our services more accessible? IDs, mailing addresses, phone numbers. You know, it's funny that our clients never used to have a phone number. Now they've got 6 numbers and none of them have any minutes left on them, you know, that kind of thing. So you know, changes in evolution and communication, it still didn't work. And then again, the ability to follow up and engage in care. When we discharge patients and we say, hey, here's a list of shelters in town, and then that's it, well, what do we expect is going to happen? So it's like, how are we doing more of that warm handoff that really can be helpful? So when we talk about trends in homelessness, here's what we're just seeing nationally. And again, all of this stuff has got a lot of evidence base behind it. And what this is going to look like in your specific hospital is going to be very different. And I'm curious, actually, just to get a raise of hands, how many people here feel that homelessness is a significant issue for their hospital? Okay, great. How many people here are involved in medical respite projects already? Okay, great. How many people here are on the cusp of or kind of looking to put some pieces in place to make that happen? Okay, scattered. Okay. What we're seeing nationally is that this isn't ending. And yes, we can go back to the point-in-time graph. We've not made any structural changes in this country to end homelessness. What we've been doing is getting really good at bailing out the tub, but no one's turning off the faucet, and it continues to flow. And so Project 25 is fantastic, but next year you're going to have another 25 folks, and the year after that you're going to have another 25 folks. And this 25 folks is actually probably more like 100 folks, 150 folks. How does it end, and where do we get ahead of this, right? But we haven't done anything to address really the housing costs in this country that are driving this. We haven't increased wages. We still have an unemployment or underemployment issue. We've got growing numbers of people who are unsheltered. The natural disasters, particularly here in California, are driving and putting pressure on a housing assistance program that is woefully underfunded. We've got a rapidly aging population that's bringing medically complex conditions, again, fueling hospital use, lengths of stay, total costs of care. And then we're also seeing across the country more and more ordinances that are making it illegal to be homeless. And so we're ratcheting up the criminal justice system because we are at our wits' end. And people are getting into that compassion fatigue where, sure, we recognize it's a problem, but then what? What are we doing? And so a couple of the positive trends that we are seeing lower rates of family and veteran homelessness. Now again, I'm a little skeptical about that, but we have made some really targeted investments in subpopulations that have seen some pretty good results. And then there's also a growing understanding and awareness of the housing crisis and impact on communities. And I think just evidence that this topic is in this conference here is evidence of that. So, talking about housing, I don't think it's a surprise to anybody to know that it's expensive to live in California. And so when they put about $35 an hour is needed because the fair market rent for a 2-bedroom apartment in California, again, averages, there's a lot of variation, is about $1,800 a month. So you need to earn at least $35 an hour in order to afford a 2-bedroom apartment. Then, if we even just look at, let's not think, people don't need a bedroom. Let's just look at the studio apartment. Let's just look at the cheapest, smallest unit possible, right? So in the state of California, you would need to earn $48,000 a year in order to afford a studio apartment. And then again, San Diego County, it's pretty expensive. You have to earn $56,000 a year. Now that works out to about $28 an hour. And my understanding is that the minimum wage is not $28 an hour. And I would imagine that your minimum wages are not $28 an hour. So how is it that if you can't even afford rent when you earn $25 an hour, what does that mean for someone on SSI? What does that mean for someone who's getting no income? And so then it's not a surprise to see that we've got a whole lot of folks who are basically just shut out of the housing system. So we've got 50% of all renters, got 1 in 4 homeowners who are struggling to afford their rent. We've got about 11 million people paying more than half their income on rent. We've got about 7 million people doubled up with family and friends. And then we are seeing a woeful reach into the rental assistance. So 1 in 5 people who are eligible for housing assistance, like a Section 8 voucher or something like that, actually receives it. So what happens to the other 1 in 4, or what happens to all of the 4 out of 5? This is a discussion. And then just bringing that here to California. So it costs $450,000 to build 1 unit of really low-end housing in California. That is shocking. I want to continue with thread because there's a couple of things that have been mentioned in both of the previous discussions. Apple was one of them. So thank you, Dr. Norris. You picked up that thread. So Apple, just the other day, $2.5 billion to invest in housing. Between Apple, Facebook, and Google, I think it is, they have, between the 3 of them, pledged $4.5 billion to build housing in California. Fantastic. That gets us 10,000 units. California needs 3.5 million units in the next 5 years just to meet the current shortage. And that's going to cost $1.6 trillion at the current rate. This is staggering. We're not going to one-off our way out of this. We need structural change to turn this around. San Diego County spends $117 million a year on housing. 60% of that comes from federal funds. But when you think about adding the 5,400 more units over the next 10 years, that is more than double the amount that's already being invested per year. So again, where does this money come from? We have to get real with the actual structural change that's needed. And the problem with talking about housing as a social determinant of health, right, is that this is not just about this administration. We have been disinvesting in housing since the late 70s. I mean, we really pushed down on the gas pedal on that during the 80s and early 90s, but we've never made up for what we were spending before. In fact, we put a lot of those same resources into home ownership, mortgage interest deduction. Before getting rid of the mortgage interest deduction in this last tax overhaul, we spent $75 billion a year on mortgage interest deduction and spent $40 billion a year on Section 8. We need to ask ourselves where our priorities are in this country. Thinking about, too, critical shortage, there's no profit. I mean, let's just be honest. There was an opportunity to talk about profit in the system at a couple of points in the conversation so far. So let me bring up profit. There's no profit in building any of this. So developers aren't building these units. There's profit in building luxury condos and luxury stuff, but not in the kind of stripped down linoleum tile kind of thing that really tends to characterize these low income units. And at $450,000 a unit, whoa, how are we going to do this? And then I think it's no surprise here, we're funded totally different in healthcare than we are in housing, and then all of those outcomes that we see kind of don't really translate across those silos. And it's an entirely different area of expertise. So this is a room full of healthcare providers. How many people here are housing experts? How many people here want to be a housing expert? Or do you dig on just being like a healthcare person, right? Like that's why you're here. Right, we don't want to be doing housing. That's not our business. We've been forced to care about this because, again, this is the broken system that's rolling up into us, and we have no choice but to double down on thinking what we can do in this effort. So let's talk about hospitals and housing. There's a whole lot of research around this, and it's going to look different in everybody's hospitals. However, take-home point, longer lengths of stay, more expensive costs per care, 3 times higher ED visits, 6 times higher on 30-day ED admission rates, and twice as high on inpatient readmission rates. Again, not a surprise, but when you're talking with your legislators and when you're talking with your board and your partners and the whole bit, we need to be pointing out that this is the kind of financial impact and operational impact we're seeing on hospital systems. Again, when we talk about like all of the weirdness, I think, was it Nicholas said earlier, all the weirdness on the outside world, we've got to like work with this. So then that brings us to medical respite care, because we talk a lot about housing, but the bridge between getting from hospital to housing a lot of times looks like medical respite care. And I know that there's a lot of different things going on with medical respite. It's one of those unlicensed kind of new innovations that people are like, we just really don't understand what we're talking about. So when we think about respite, it's that post-acute care. It's you need this person's ready for discharge, and if they had a house, then you would discharge them home for rest and recuperation. But without having any place to go, what do? You need a safe and legal discharge option. So medical respite beds, I mean, these sometimes can just be medical shelter beds, or they can look lots of different ways, but it's important to note what they're not. They're not skilled nursing. They're not a nursing home, they're not assisted living, they're not a behavioral health step-down unit, they're not supportive housing. These are very specifically tailored programs. Again, across the country, they vary by size and facility type, but they offer the space to do the kind of work that the last panel was talking about. How do we get a good care plan in place? Sometimes we talk about how our patients don't have one case manager. They may have 6 case managers, and none of them are talking together. And so we're talking like a Ponzi scheme of case managers. And so it's thinking about like, we need a case manager for the case managers, and then it just becomes best practices and case manager coordination, and then all of a sudden it's just become too crazy. So how do you have a space where you can take 3 weeks, 6 weeks, sometimes a couple of months to really do the kinds of intensive service package that's needed for really medically complex people? How do we integrate that into primary care and make sure that your guy is connected to where he's supposed to be getting care in the community and understands how to access that, making changes if that's needed, that we'd really just case manage the hell out of him, and then make sure that he's getting good self-management support. Does he understand what medications he's taking and why? Does he understand when he takes them? Does he understand how he can reduce risk to himself for behaviors that he may still continue to engage in? How are we part of making it better? Harm reduction, motivational interviewing, the space to be able to get on top of somebody's issues and then work through it in a more rational way, which includes doing the housing and doing all of the housing coordinated entry piece so that your guy ideally comes from your place to medical respite into supportive housing. And that's the kind of continuum that we are envisioning, making sure that medical respite can be part of that. We've got about 60-some programs across the country that we're aware of. I think we're going to see a lot more of these in the next 5 years because people are really recognizing that that's the gap we now need to address. So when we talk about what is medical respite treating, a lot of this can be anything that you want because every program has got different admission criteria. So a lot of medical stuff, though, that holds people up in inpatient can be done in medical respite. So thinking about what is it that you're doing? What are the codes that you are most often affiliating with patients who are homeless, who are in your inpatient or in your ED? What do they need? What's the piece that they need that would work well, and how are we gathering that data so that we can make an analysis on, okay, if we have a medical respite program, these are the top 5 conditions that it needs to be able to treat, and having data to back that up, because you're going to then need to be able to staff that appropriately. And we all know that a nurse case manager, worth the weight in gold. But if really what you need is a nurse case manager, don't do it on the cheap. Because doing this on the cheap, you get what you pay for. And so thinking about the staffing, the case ratios, all of that, when you cost it all out, what will it really take? Still be cheaper than being in your bed. The facilities look all different ways. Apartments and motel rooms can be one option. Homeless shelter is obviously a really easy way to get started and maybe grow from there. Standalone facility is also a possibility. And again, we're seeing more assisted living in nursing homes do a program for this within their services. So again, when we talk about the advantages of medical respite, as you turn around to then articulate this to the partners you need with you in moving forward, this is the kind of piece that we need to talk about. And when Nicholas talks about disruptors and talks about the patient or the customer experience, I think of this in the terms of like a triple aim framework, right? How do we decrease cost, improve population health, and improve the patient experience? All of this is possible using medical respite. We've got a paper that kind of goes more into detail about how the triple aim approach and medical respite work well together, but looking at your performance measures, looking at the data, making sure that you are establishing value and quality It's very easy because this is such an obvious piece. So again, and I want to come back to the safe, legal, cost-effective discharge option, and thinking about how we're improving health. A lot of times we think too about, well, these are unlicensed programs. We're desperate to get folks out of our hospital beds. And so, oh, there's a Bob's Bargain Basement medical respite program down the street. I'm gonna establish a relationship with them. I'm just gonna send my patients there. And it's a dank basement with a couple of cots and someone who says that they're a case manager visits twice a week. Is that what you need? No. We need to have a standard of care for this. And I know that we kind of get stuck in the credentialing, licensing kind of piece, but it's very possible that we can adopt standards here that really reflect a high quality care program that we can get behind. We've spent a number of years at the National Council developing standards. These are available for you. Please use them. Really excited to see this moving forward. You sure I'm on time? Okay, common funding sources. So we've got hospitals. Probably not a surprise, one of the biggest funders of those 60 programs that we're aware of. But you are seeing a lot more people getting interested in this. And there's a number of ways to pay for them. Per diems, annual grants, purchasing bed nights. There's a lot of different ways you can structure it. A lot of this might just depend on what works best for you and for your operations. And then how do you make the case? How do you make the case to your funders to say, hey, we've got fewer hospital days. We've got reduced readmissions for inpatient. We've got reduced admissions for the ED visits. This is just a handful of cities that have implemented medical respite and what they've seen as a result. Everybody's going to be different. So you could run the same exact program here in San Diego in different places. You'll get different results. But all of these results will be better than doing nothing. And then a lot of the fine print down here, I'm a big fan of source material, so you can look up all of that. I think there's also a role for talking about the right thing to do. And this is not a message, I think, for this room. I think we get that. I think that we are at a place in our country where we are having a discussion about healthcare that deserves a moral framework. And I think hospitals have a lot of political capital, have a lot of social capital, to be able to stand up and say, it's not just cost effective, it's not just high quality care, but it's the right thing to do. And we can be at the center of driving a conversation that is a values-driven conversation about what healthcare looks like in this country. And why hospitals? So you just, in your most recent needs assessment, there's 10 biggest issues. Access to healthcare, community and social support, economic security, education, homelessness and housing instability, unintentional injury and violence, aging concerns, behavioral health, cancer, chronic conditions. All 10 of these things are either explicitly or implicitly touching on homelessness and housing instability. All of these things are driving it. And then the focus on cost, outcomes, liability, and then the mission of the hospital, again, coming back to the values piece. So I think hospitals are just really well poised here. And then at the same time, brand new action plan coming out of San Diego that specifically mentions medical respite care being part of the solution. And how do we stabilize people in response as we're getting them into housing? And so part of this is, and this just came out, but guesstimate, 100, 150 medical respite beds for San Diego County. Is that the right number? Do we have the data to determine what is the right number, how are those dispersed in the community, and how are people sharing responsibility for those beds? I think that's the data and the discussion that needs to happen at this point. And next week, Karin, along with my colleagues at the National Council, are coming in to talk with the continuum of care here in San Diego about how we do move this forward. So I'm really excited about that. And I'm also excited about the new CalAIM proposal. So talking about a whole chapter on in lieu of services, which includes supportive housing and tenancy supports and all of this, but also explicitly talks about recuperative care. Providing housing for up to 90 days, meals and monitoring, talking about how we can include ADL assistance, case management, all the things that we've been talking about. Making this a statewide benefit really gives us stability and a consistency to this kind of program that's needed in the gap. But how are we participating in the hospital side to really make that a reality? So I'm excited to see how this evolves. And then there are 4 actions that I'm just thinking are ripe for you to think about. And you may be already well into a number of these, or it may be something that's kind of skirting around on the periphery. But one, I'm sure a lot of you are doing lots of different screenings for social determinants of health in your hospitals. But how are we operationalizing the data from those screenings? How are we coding those so that we can run reports to really determine what is the impact of homelessness on your hospital, on your operations, and on your workforce? So one of the things that I'm thinking back to Nicholas in his keynote was, did anyone ask the nurse what would make it better? Nurses and your ED physicians and your discharge folks will say, the frequent user homeless patient is really, really hard to accommodate when you're trying to run a large operation, and there are better ways to do it. But thinking about how do we have the data to demonstrate what the investment is needed? And then, how is it that we clarify the definition of medical respite to make sure that we are not investing in Bob's bargain basement that is actually not going to be the solution that we're looking for? How do we develop a standard of care? How do we identify sustainable funding mechanisms? Talked about CalAIM, talked about a number of ways that hospitals are financing these programs in other areas of the country and even here. And then also talking about how do we advocate for the structural solutions to housing that we know are needed in order to stem the need for this entire conversation. We could be talking about diabetes best practices. And maybe we're tired of diabetes best practices and cardiovascular disease, but probably not, because that's still what's killing people in this country. And it's a healthcare issue. And I'm coming back to how many people here are housing experts? Right. We need to be talking about healthcare, but instead we're talking about housing because the crisis in housing has become the crisis in healthcare. How are we using the political capital of the hospitals to call attention to the systemic solutions that are needed? And this is at the federal level. The federal disinvestment has basically left counties and states to twist in the wind and figure this out. And it's left patients living under the bridge or in their car without any appropriate care. And then finally, I want to end with a little cartoon here. And this kind of comes back to Nicholas's pieces too, about being a disruptor, doing things differently. We can't do sameness. So I would argue that I don't want my gas station attendant measuring my A1C. This is like not how I see quality in healthcare going. At the same time, we should raise hell about the fact that we are having this conversation. We should be raising hell to the fact that, is this our business? Sure, it absolutely is. But it's also not our business to inherit a fundamentally broken system that leaves us in the position of solving it when we are not going to be able to solve this in healthcare. We can do the best we can to keep bailing out this tub, and we can do the best we can to be able to improve health, lower costs, do all of that. But it's like without any help here, without somebody turning off that faucet, we are going to exhaust ourselves bailing out this tub and working with these kinds of structural problems. So how do we walk and chew gum, right? And I think Dr. Norris talked about this earlier too. We have to be doing both short and long-term solutions at the same time. We have to be investing in medical respite care. We have to be investing in projects like Project 25. We have to be doing these kinds of pieces. We have to keep bailing out the tub. But we also have to be turning off the faucet. We have to be demanding that our federal responsibilities are upheld. And I find this to be the conversation that we need to have. And then one last thing, because I don't want to be the only person not to mention single payer. If we want to talk about being a disruptor, and we want to talk about raising hell about broken systems, I think that's also where we need to be. I know that's not the scope of the conversation I was asked to have, but I do think that fundamental changes to health and housing are needed in this country, and I think hospitals and hospital executives are really strong people at a table to say, this is not working and we need something different. Thank you. I really appreciate the conversation today. And I think with that, we have a few minutes for questions.
We do. We have a couple minutes for questions. And while you're thinking of those questions, Barbara, thank you for a fascinating conversation. You're obviously very passionate and it's very timely discussion. Along those lines, I also do want to give credit where credit is due. Recently, we've had conversations with Dr. Buchert and Promise Health Plan here, and they also agree that there's responsibilities and things that they should be doing. And for those who aren't aware, they actually do pay for recuperative care, both here in San Diego as well as up in LA. So,
Excellent.
Kudos to Dr. Buchert for putting himself out there and his plan out there, and it's definitely well received and well appreciated. So with that, any questions folks have? I'm sure there's questions out there because there was a lot packed into that presentation.
There's a lot packed in.
Jeff Gearing with Family Health Centers of San Diego. In your scan of what are the best practices in recuperative care in the country, have you seen strong practices with the intersection of medical and behavioral health services, particularly mental health and substance use services, given co-occurring disorders that are occurring with the frequent flyers to the ED or to hospital admissions? And what strong practices have you seen in that area?
I agree. The behavioral health piece is one of the things that can really make or break the placement. A lot of this just depends on how it's staffed. So you can develop a program, and we do have programs that are operating that can accommodate both medical and behavioral health. A lot of times it just depends on how significant is the condition, are the conditions that need to be managed, regardless of whether they're medical or behavioral health. It's how you have it staffed. So for example, in Boston, where we have I think a gold standard program of a standalone medical facility, they can accommodate pretty much everything. But then when you go to a small shelter-based program, they may not be able to accommodate significant behavioral health issues. So a lot of this just depends on what's the population that you really need to do the intervention with most, and then tailoring and staffing a program that meets that. I think that's really kind of the piece of it. Is it because I mentioned single payer? Don't let that be a chilling thing.
All right, we got a question over here.
If you were homeless, where would you like to live so that you were the healthiest person among other homeless people in the U.S.? What communities do the best job, and what do they do differently?
Wow. If I were homeless, I think there's a couple of things there. If I were homeless, first of all, I wouldn't go to a shelter. I'd live on the street. And I'll tell you why. Because I love my husband, and I don't want to be separated from him. In our shelter system, we separate families. We separate people that we love the most, the people that offer us protection. So it is a reasonable and rational human choice to live outside rather than shelters. And I feel like there's a discussion, too, that we need to be honest about, is people choose homelessness. I absolutely am going to answer your question about locality, but I feel like there's a bigger piece here, is how do we characterize people's choices and where they choose to live, and where we ask ourselves, what choices do they actually have? So if I were homeless, I would probably eschew the structure of a shelter, and I would argue that all of us as adults do not dig on curfews and don't dig on being treated like a child, because that's, I think, what shelters do a lot of times. So because of that, I would be living somewhere warm, someplace like California, where it's sunny every day. I'm coming from Baltimore, and it was really cold when I left yesterday. And when you get off here, it's so beautiful. People are so nice here, too. It's wonderful. Fruit grows right on the tree. So I just fell off the turnip truck. And but yeah, it's the kind of thing where living someplace warm, living outside, these are rational places. Now, I think where you're really going is who has kind of the best system for where I would want to then go in order to end my homelessness, right? And I look at communities like Portland, only because I'm really familiar with Central City Concern, our healthcare for the homeless there, and the incredibly comprehensive service model that they have. I definitely would not go to a Medicaid non-expansion state, because that's terrible. I want to actually qualify for the services that I need. And so Hawaii seems cool. I'd like to live on the beach. But again, it's the kind of thing where I think California is at the cutting edge of a lot of this work. I think the West Coast in general is really, I think, probably not a surprise, ahead of the rest of the country in more thoughtful, comprehensive systems that include a lot of entryways that are lower barrier for people to access, and then get into a system where you have an agreement that it needs to be coordinated and an agreement that we're actually tracking that data. So I'm not being flip when I would say California is a good place only because you've agreed that this is a problem that has to have a thoughtful solution. And I'll tell you what, not everybody in the country is there with that yet. Acknowledging that there's a problem is an important first step, and then a second step is actually doing something about it. California checks both boxes. And so, but I also want to push back on the idea that people are actually moving to places like this. Like homeless people don't move to California because of the awesome homeless services system. There is not like a street paper that has an analysis of homeless services systems and says, hey, if you go here, like none of that happens. Like the resources just, like that has been disproven over and over. But I'm rambling at this point, but I just do appreciate the conversation. I also want to appreciate the choices that people don't have, and then how we interpret and then label those choices.
Barbara, last question.
Oh, sure.
Thank you, Barbara. The question I have is, do we have a proper definition of homelessness? I think of doubled up, tripled up families, as well as I think we overemphasize adults in this population. What about the kids? What about expectant mothers? And why so much attention on the adults versus those other more vulnerable aspects of that population?
All right, so we've got, it was a multi-part question. Why the kids in other vulnerable populations, and then the first part was?
A true definition.
True definition of homelessness. I have to say, one of the things that was a surprise to me when I came into this job about 10 years ago was the screaming matches over who's homeless. That happen at the federal level, both in government agencies, but then also even in the advocacy community. I can sit at a table with a bunch of my colleagues, and we will have it out over who counts as homeless. And we've got, I think, 4 or 5 federal definitions of homelessness, depending on which agency. So HUD does not recognize doubled up with family and friends as homeless. But the Department of Education does, and HHS does, and so that kind of gives us some wiggle room when we're working in the healthcare system. But then when you try to bridge and integrate health and housing, which often looks like bridging HHS-funded services streams with HUD-funded housing streams, you start getting people getting caught between. And so what happens is, if you, very well-meaning, even if you put your guy into a motel for a few nights, you might blow his chronic homeless status. Now he no longer qualifies for supportive housing. Like, these are the kinds of definitional things that I think, when we talk about the homeless industrial complex, we are kind of building these structures to support homelessness that don't actually end homelessness. And so these are the kinds of things I see. And then why the focus on single adults? Well, they're the scary population, I would argue, right? The homeless kids are adorable. Homeless kids are the kinds of sympathetic population that our policymakers will go to the mat for. But as soon as that 8-year-old turns 18, what do? As soon as mom gives birth, what do? Kids are sacrosanct in this. And it's not to say that a third of our shelters are full of kids. A third of our shelter users are children. We have families that are in dire straits. But I would argue, what's the difference between chronic homelessness and family homelessness? Nothing but time. We did nothing to support a family. And so then dad split off and mom lost custody and kids in foster care. And we'll give $1,500 a month to a family to take foster care rather than giving mom and dad $1,000 a month in rental assistance. This is insane. Our single adults are the broken population, but they started out coming from somewhere. They started out coming from families. I think it's disingenuous when we even talk about subpopulations to begin with. Much like it's disingenuous to talk about how diabetes has nothing to do with mental health. We segregate conditions just like we segregate people. So that's kind of my gut response to that question. I do think, though, that if we do start making structural investments, we have to be looking at childhood and family trauma. And we talk about child trauma as if it still is still just happening with kids. But I would argue my 50 and 55 and 60-year-old patients that are at HCH, childhood trauma. Everyone we are treating is working in a traumatic space. And so I think it's important that we kind of address the whole family or all populations. Again, I don't want to say that kids aren't important. Obviously they are. But I think it's hard to say kids are more important than adults. And that might actually get me like booed off of a stage, possibly like now. So I know my time is up, so that might be a good place to start, saying I do care about kids, but just not to the exclusion of their parents.
So let's go ahead and give Barbara a round of applause if we would.
Thank you.